agreed that I will talk about something about which I am very passionate about. That is about the use of NIV in neonates and how to optimize it. Now, in the next kind of 20 minutes, let me just give a brief overview of the various modes of respiratory support which could be used in a newborn. We'll talk about the physiology behind non-invasive ventilation. See, morning we are talking about how to explain, even to a kid, we need the reasons. Thank you. So for us also, we need to understand, we all use it. I'm sure anybody who has worked in a neonatal unit has definitely touched it in CPAP and have used it, but without even really thinking about the physiology behind it, and there's a lot of physiology more than to what we see or what we think. And then a little bit about the clinical aspects, and finally touch upon the various ways of optimizing the use of neonates, NIV. Now, when we have a child like this, okay, what are things which you will do? Obviously, he's hypoxic. We want to give oxygen, isn't it? That's the easiest thing to do. We give oxygen, saturation improves, we are very happy. Okay, we say that, fine, fantastic, we are done. But definitely that is not, that's what we have done for quite a long time. And then when the child becomes very sick, we moved on to other modes. One is actually what during my years of training is more about ventilation. Go straight for ventilation. You tube the baby and then you ventilate. But now we have come up with a much better way of handling, which is a non-invasive ventilation or NIV. Now what do I mean by a non-invasive ventilation? Basically we are going to support the respiration in a spontaneously breathing child without a endotracheal tube. The key component here is a spontaneously breathing child, and the second thing is in a non-invasive manner. Now let me just talk about 30 seconds about why oxygen is bad. We all love oxygen. Without oxygen, none of us are here alive, isn't it? We are all dead. But please remember that when we give oxygen, it is also a poisonous medication. Oxygen has to be prescribed, at least in the West. Unfortunately, in India, we don't. We just leave a baby on 10 liters of oxygen and forget it, eventually till the distress settles down, without even thinking for an iota about the injuries it could cause. So what are all injuries it could cause? Obviously, there is a lot of oxidative stress due to the reactive oxygen species which is generated because of the oxygen. Of course, our body has some antioxidant defenses, but they are just not sufficient. So in a neonate, what does it can cause? The biggest problem is ROP. We have heard about innumerable cases where very famed neonatologists have been sued and lost lakhs and crores of rupees as compensation. BPD is something which comes more and more with many neonates are surviving. Of course, the neuro disability is always a problem, but beyond all that, we just do not know. We have no way of quantifying the amount of tissue damage which happens for the rest of the tissues in the body. So let us love to hate oxygen, that's what I would say, and give it only when it is absolutely necessary. Oxygen is definitely a necessary evil. Okay, so let's do what we all did, 20 odd years back, which is to, when the child becomes sick, intubate and ventilate. Now ventilated induced lung injury, VILI is something which has come up quite a bit in this past decade or so. We know a lot more about the barotrauma, which is related to the pressure, the volume, volutrauma. Beyond that, the moment we tube a baby, we intubate a baby, we are removing the natural PEEP which is there. So basically, as a result of which, there is a natural tendency for the lung to collapse. So we get an atterolectric trauma, and of course, we introduce all the choices of the organisms and cause of biotrauma. Apart from all this, okay, somehow we manage to salvage the baby, and when the baby becomes better, the baby's lungs are not developed properly, and we land up with a bronchopulmonary dysplasia. And the incidence in some centers is as high as 50% for babies less than 32 weeks. Just imagine, every other baby develops significant breathing difficulty. So it's not something which is nice, and we could see if we can avoid it. So a lot of research has gone, and the first use of the non-invasive ventilation in the form of CPAP came about 50 years back in 1971, when they noticed that NIV definitely helps babies. But before I delve into the topic, I just want to go into some of the basic limited physiology. first step is about what is so unique about neonates. Okay, they have a structural immaturity, so as a result of which their lungs are very compliant. But the bigger problem is that they have a natural inability to maintain the functional residual capacity. Now, what does this mean? See, functional residual capacity is basically the amount of air which is present within the lungs to make sure that it does not collapse at the end of expiration. But in a child who has got very compliant lungs, that's not going to be enough, and so it does collapse. So, as a result of all this, we have a low lung volume, increased airway resistance, decreased pulmonary compliance, obviously as a result of all which the baby is going to work hard. Now, two terminologies I want you to remember. One is the partial pressure, second is the pressure gradient. What does all that mean? Now, partial pressure is basically the pressure exerted by a particular gas provided that it occupies the whole volume. And at air level, we know the pressure is about 1 atmosphere or 760 millimeters, and oxygen gives a partial pressure of about 159 millimeters. Now, you might be wondering why I talk about all this. Because the moment we add a CPAP pressure of anywhere between 5 to 10, the positive pressure, the partial pressure goes up. And sorry. So, the second one which we need to remember is about the pressure gradient. So, how does oxygen reach the blood? Very simple, because there is more oxygen, and then the extra oxygen tries to equilibrate with the place which is less oxygen. That is a natural phenomenon with any fluid. So, you get they try to move from a higher gradient to a lower gradient, and that's where you get a equilibrium, and that's how it moves on. And vice versa happens with carbon dioxide. So, these are the two phenomena we need to remember, two technologies we need to remember. Now, this is something which we keep talking about a lot, that is VQ. Now, what is a normal VQ? So, basic idea is wherever alveoli are ventilated, we want blood there so that it can do this equilibration. So, okay, so oxygen can move into the blood. But in real life, that's not the case, because in the upper lungs, the ventilation is always better when compared to the perfusion because of the effect of gravity. Even for a newborn baby which is lying, depending upon the position, again the upper part, it's going to be, the perfusion is going to be lower than the ventilation, and vice versa happens in the lower part of the lungs. Now, on average, if you look at it, only about 80% of the lungs contribute for any respiration. Now, in a child with any kind of respiratory distress, this goes down dramatically, and the VQ mismatch could be as low as even 20 to 25%. So, sorry, the lung contributing is only 20 to 25%. I'm just going to skip all this. So, what is CPAP? This thing. What are the various modes actually? NIV. Whatever modes we talk about, the basic idea is that you apply a constant positive pressure for a baby who is breathing both during inspiration and expiration. That's what it means. Now, let us see what happens. Now, the first part is a baby who has got a respiratory distress, who is working hard. He doesn't have been given a CPAP. Let us say this child has been given only oxygen, and his oxygen saturation is maintaining. So, what basically happens is, as you could see here, is that the pressure to collapse is very, very high. And the atelectasis, as it happens, the pressure to continue to collapse becomes even more, and you can see the massive amount of collapse which can happen. Now, just see what happens when we give a positive pressure. The tendency to collapse is much lower, and the pressure to collapse is even lesser. Okay, these are all based on the Laplace principle. I just don't want to bore you guys, but I'm happy to discuss independently if anybody wants to. So, all the CPAP does is to change the pressure gradient. So, what it does is, in a typical patient, let us say we go up to a maximum pressure of 10 centimeters, your oxygen, the partial pressure of oxygen goes up by about 2.25%. As a result of which, you just think about it, we are forcing more oxygen. Even at a FiO2 of 21%, the amount of oxygen which gets forced into the blood is higher than what we can do without pressure, positive pressure. So, even though this may not look very great on the paper, but it has a very significant impact. So, how many times we have seen babies who have been just put on CPAP, initially no saturation, and within a matter of 2 minutes, the saturation has gone up to normal. And that is the reason why it happens is because of this. Apart from that, there is a lot of mechanical effect. Okay, what it does is it increases these basically the size of the pharynx. Okay, the diameter of the pharynx, so air can flow in bit more easily when you give CPAP, and it also prevents the airway from collapsing. So, result of all this is that there is a better pulmonary compliance, decreased airway resistance, and resulting in increased oxygen levels without giving oxygen. And the key point here is without giving oxygen. As I said, you always love to hate oxygen in a baby, giving oxygen in a baby. So, we are achieving what we want to achieve by giving without giving oxygen. So, now, okay, so now we have agreed that giving CPAP is the best way. What are the different ways by which we give? And this is where the mimicry comes. Okay. So when we talk about a NAV support, there are two ways. One is to give a constant airway pressure. The second is to give a variable airway pressure. And within the constant airway pressure, we could either use a nasal cannula based on a low flow, or you could use a high flow heated humidified flow, which is getting very popular these days. Very relatively easy to use with its own problems. But CPAP is something which I literally love. Okay. And there are different variations are there. There is a constant flow CPAP based on where you just set the flow, let us say 8 liters or 10 liters or whatever it is, and then the pressure kind of is set constantly also at the same time. So you get a conventional and of course the bubble CPAP. And then we have a variable flow CPAP where it basically senses the amount of flow which happens and modifies. So you don't give excess flow at all. Now, the variable airway pressure is something which responds to the baby's breathing. So, you get so there is some increased pressure during inspiration and then a decreased pressure during respiration. And when it is synchronized, of course, it synchronizes with the baby's breathing. So, you have the intermittent positive pressure ventilation or synchronized intermittent positive pressure. We have the nasal BiPAP and also the nasal high frequency ventilation. Let me tell you, if you are in a research limited setting, the variable high pressure devices, all of them are very expensive, and we'll talk about the relative advantages at one of the later slides. So when do you want to give? Baby has got apnea of premature, he's breathing, stops breathing, and then he breathes. Wonderful device to use. In any baby with any kind of a respiratory device, provided they have a good support respiratory drive, please use it. In a baby who you want to prevent collapse of lung, like for let's say a baby who's got a muscular problem or a baby who is heavily sedated and you want to prevent collapse of the lung, in that case you could use and a wonderful tool for post extubation. So that way, see, when you use NIV, we are actually mimicking, we are supporting normal ventilation. So we are basically continuing without negative pressure ventilation. Whereas when you are ventilating, you are actually moved on to a totally abnormal form of ventilation, which is a positive pressure ventilation. Of course, there are a few contraindications. Baby is not breathing, no point in giving CPAP, understandable. If you have got a facial surgery or a massive cleft, you may not be able to use it. And when there is a air leak syndrome, it's a relative contraindication. If it is not a tension pneumothorax, you could still get away with it by using CPAP. If there is a tension pneumothorax, you have to be very careful and probably wary of using CPAP, and better to go for a non-invasive ventilation. Now the first question which comes is it really works? Okay, I keep bragging about how good NIV is and what all it does. So first thing is, there are a lot of very major trials which have come, the COIN trial, the support trial, the Oxford Vermont Network Delivery Room Management trial, all of them have pretty much shown this. It reduces the mortality risk by 48%, pretty much half. It reduces the risk of need for surfactant and mechanical ventilation by another half, which essentially means the babies can go home faster and you don't need to keep shifting your babies unnecessarily. So it is very much useful when you can use in smaller peripheral centers. Now, the bigger question which often comes is, okay, it happened in West, what about India? Because we recently know about the Helix trial where they came up saying that it does not work in India. Cooling in babies does not work. Indian babies don't like to be cold, which is itself is a different topic altogether. But there is one study, which has looked at this, and then it very clearly says it definitely works in our population also, so we better continue using it. Sorry, So, does it mean that it is a utopia? You got the best one to use it, but please remember it's not. The incidence of nasal trauma is something which can happen, and it is really very bad. I mean, see, this baby went home alive, I think X27 weeker went home alive. After 2 years, parent comes and still keeps scribbling to me that the baby's nasal bone is collapsed. Okay, I cannot do a lot about it. In fact, it's 3 years. So, nasal trauma is a major problem. The second one is pneumothorax. So, though it may not be as bad as ventilation, but it does exist and we have to be wary of it. I don't know how well you can appreciate, but you can definitely see the distension. Okay, you can see the distension of the intestine, which is very obvious. This child does not got NAC. It is just a CPAP belly, which happens because of the, see, airway takes the pathway of least resistance. In a child who is working so hard, the pathway of least resistance is not into the lungs, it is into the gut, because it goes through the esophagus. So it takes the pathway of least resistance. Of course, all the other problems of barotrauma and valve trauma does exist, but it's not as bad as. Now, how do you want to look at it when you put the child on CPAP? This is what happens. The respiratory rate comes down, the respiratory work of breathing comes down, there is improved oxygenation. The most important finding for me is the improved lung volumes on the X-ray. So, whenever you look at the X-ray, look at if it's at least 8 ribs. Until the 8 ribs have not come up, okay, that means the posterior ribs I'm talking about, that means you have still not expanded the lungs adequately. Now, when I want to use a NIV, what are things I need? I do need a pressure generator because we need a continuous flow. So, we do need a pressure generator. And we need a gas source, obviously. And then we need a patient interface. And then we'll talk about this part a little bit more. Now, what are my problems? Why should I continue using it? Okay, so what will stop me from using a CPAP? The most important thing is about the cost. Generally, constant flow devices are much cheaper, but even they are very expensive. They are not that cheap. They are still expensive when compared to all the synchronized modes and then NIPPVs. Now, please, because you cannot put a baby on CPAP and then say, fine, I'll go and sleep at home. Because these babies can develop a CPAP or a respiratory failure anytime, and then that can make things worse. Okay, the usual initial setting, anywhere between 5 to 8 centimeters. I go beyond that, but again another but probably the recommended is about 7 centimeters, and FiO2 is as much as required, but definitely don't go beyond 60, which means you are basically losing the fight for a long time. So what are the interfaces we have got? We have got a nasal mask like we can see here. We can have a short prongs, binasal prongs like the Hudson prongs, or we can have the nasopharyngeal prongs. Personally, I use the first two and not the third. Now, coming to the last bit. So, we know it is useful, we know it works. What about how to make it better? Because we know it does create a lot of problems. So, companies came with brilliant ideas. So, why not the various other modes? So, they looked at nasal CPAP with NIPPV, found that yes, definitely it is a bit more efficient for prevention of respiratory failure and for reducing need for intubation. And definitely there is, but it does not have a decreased incidence of BPD. What about BiPAP, one of the other modes? Very similar story. Then they thought, why not compare between BiPAP, which basically BiPAP is fixed. You got a fixed inspiratory time, fixed expiratory time, and you have inspiration, you got a higher flow. Expiratory time, you got a slightly lower pressure, and then you compare between the two. And then synchronized mode, again they found it does not make a very big difference. But one thing for sure, and this is something which probably I want you guys to take home. Heated high flow HFC as a primary mode of respiratory management is not a very good mode at all. In fact, as you could see in the IPSA trial, they have to discontinue the trial because there are too many babies who are becoming sick and then even dying. So, it could be used as a post-extubation support but not as a primary mode. Synchronized, there are a lot of reported advantages because the companies always claim, because it costs about 7 to 8 lakhs, they always claim a lot of money, but studies have shown very similar efficacy. Regarding the timing itself, there are not very many studies, but one thing for sure, if you give CPAP early, the earlier the better. Okay, there are few studies which talk about it. Now, this is something which I love, and probably I can make myself very controversial here. Because most people get scared when they use a pressure of anything more than 5 to 7. I am very happy my unit standardly follows a standard of 10 centimeters, and I will tell you the results of, shortly show you the results of my unit. The pressures could be as high as 10 centimeters, but what it does show is that there is not very high, it does not have impact. High pressures, there are studies to show it does not have a cardiac impact or an impact on work of breathing. So, it's not bad. Now, this is the data from my unit, unpublished, it's in the process of being published, but just look at it. In a standard pressure, which is at a pressure of less than 8, you will see 20% landed up with the ventilation at much smaller numbers, out of 2 out of 10. Whereas when you look at a bigger number, out of 49 babies with high pressure on meconium aspiration, which again is another controversy, you see none of them landed with ventilation. So, wonderful, consider using it. Okay, those are the numbers to talk about. Now, regarding the prawns in the mask, again, generally people say there's not a much difference. My personal experience is very different. But one thing we feel, do not hesitate to give surfactant for a baby who is on CPAP. Feel free to intubate and give if the child ever needs more than 30% of FiO2 after 1 hour of your NIV, whatever mode you are used. However much the child looks like the child looks better, just do not hesitate, it will come back to bite you. So let me just conclude by saying that definitely in the last quarter of century, NIV and particularly CPAP, I'll say, has become the main modality of treatment of child with respiratory distress, and definitely has replaced invasive mechanical ventilation. The different modes people try about it, but beyond CPAP, I'm still happy with CPAP and gives me wonderful results. Okay, but please look at beyond modes. I will want you to look at various aspects which we just touched upon briefly to improve your CPAP management. So thank you very much for your patient listening.